Hello, my name is Caio Morais. I'm a researcher and a physiotherapist at the Federal University of Pernambuco in Brazil. In this video, I'm going to discuss about PEEP titration using esophageal manometry and electroimpedance tomography. This method requires the use of a catheter with a balloon that is inserted in the esophagus of the patient. The change in esophageal pressure is a surrogate of change in pleural pressure. To have a precise measurement of change in pleural pressure, we need to consider the correct position of the balloon and fill the balloon with a precise filling volume. Using esophageal manometry, we can measure the end expiratory transpulmonary pressure, which is a variable well correlated with lung collapse and overdistension. We can also use esophageal manometry to assess the swing during the inspiratory effort. The end expiratory transpulmonary pressure is frequently used to titrate PEEP. In general, we try to keep a PEEP level that keeps the end expiratory transpulmonary pressure slightly positive to minimize lung collapse. There are many methodological aspects that we must consider using esophageal manometry. Unfortunately, there are some limitations that difficult the use of esophageal manometry for every patient. Some limitations are related to the patients that are contraindications of using this invasive procedure, and others are technical limitations when we can't have reliable measurements of esophageal swings. With electroimpedance tomography, we are able to measure the distribution of lung overdistension and recruitable collapse during a decremental PEEP trial. In recent studies from our group, we found that the PEEP level to minimize overdistension and lung collapse matched with a slightly positive end expiratory transpulmonary pressure. This means that using ENLIGHT, we have a non-invasive option to have the same PEEP as using esophageal catheter. In addition of having comparable values of PEEP using EIT or esophageal manometry, with EIT we can precisely identify the regional differences in the overdistension and collapse distribution. The use of esophageal manometry requires some technical skills. For instance, if we overinflate the catheter not considering the esophageal elastance, we may overestimate the pleural pressure, and consequently we may use more PEEP to keep a slightly positive end expiratory transpulmonary pressure, when in reality we are probably inducing lung overdistension. The main advantage of using ENLIGHT is because we have a non-invasive method that provides us similar results compared to the esophageal manometry, that's an invasive procedure, and EIT is easy to use and give us regional information about the lung function.